A very good afternoon to all. I'll be presenting a paper on the histopathological evaluation of major organs in severe acute respiratory syndrome related coronavirus 2, or now as it's known as COVID-19 disease cases by minimally invasive autopsy technique. So this picture has been etched in our minds and we've been seeing this everywhere since the last 2.5 years. And this single-stranded enveloped RNA virus with these glycoprotein spikes is responsible for the COVID virus. And it was initially known as SARS-CoV-2 because of its genomic similarity to SARS coronavirus, which was seen in 2002 in China. And today we have enormous literature, we have research, treatment trials, we have vaccines, we have COVID drugs coming up. But what about the time when it all first started in late 2019? When the first case was detected in the Wuhan district of China, and soon there was an outbreak of pneumonia cases in late December. And by the start of Jan 2020, we realized that what we are dealing with is something new, something different. But when the first COVID death occurred, it got the world's attention. And the virus now is no longer in China, it's all over. And the epicenter being in Europe, and Spain, Italy, Germany, Iran taking the heavy toll. And it took just 93 days for it to turn from a mystery virus to a pandemic, with the cases surpassing 1 million. And as the cases start increasing, all countries start implementing lockdown measures, they start banning international travel. There is compulsory mask, hand hygiene implemented, which saw a decrease in the COVID cases. A similar trend was expected in India. But come June, the number of death cases suddenly started increasing. And the same picture was seen in Mumbai. So this pandemic was turning into a long nightmare with no end to it. And there were a lot of questions that were yet to be answered, like how do we test this effectively? How do we, in a country like India, how do we prevent? And how do we treat it? But the absolute dark we were in regarding what are we dealing with, what is the pathology. So where do we find these answers? Now the answer lies in those who have been infected with COVID virus. So no invasive procedure was allowed except life-saving at that time. And so the patients who died of COVID were the only people who could give this answer. So the first autopsy was performed in Spain by two brave pathologists, following which Italy conducted its first autopsy study on 38 cases, focusing primarily on the lungs. ICMR at this point of time issues a guideline that no unnecessary autopsy should be performed. In Mumbai, St. George Hospital gets converted into a dedicated COVID-19 hospital, with increasing cases and no literature as to what are the autopsy findings that we see in Indian patients. Heads of three departments, Department of Surgery, Radiology and Pathology, they decide and come together to research and perform autopsy on COVID patients. Since open autopsy could not be performed due to prevailing guidelines, with a little brainstorming, minimally invasive autopsy technique was decided upon, in which it is a needle-based approach and the tissue samples can be collected without exposing the healthcare professional who is taking the autopsy. As the death of the patient was notified to the surgery residents, went in the ward and they informed the next of kin that we want to do a study on minimally invasive autopsy. Would you like to participate? And the consent was taken accordingly from the next of kin. And these patients were then taken into a specialized room having portable USG, and this USG was used to identify a representative site in the target organ, and these sites were then cleaned and 2 mm incision was given. These sites were then cleaned and a 2 mm incision was given and 4 needle biopsy guns were used in which specimen cores were taken from major organs. This study was a prospective observational study which was conducted during the peak of the pandemic between August to November, and 51 patients were diagnosed at that time were included. And the minimally invasive autopsy was performed on lungs, myocardium, liver, kidneys, pancreas, peritoneal fat, and spleen. Pancreas and peritoneal fat did not show any significant finding, and organs such as brain, stomach, intestine were not included in our study. These biopsies were then preserved in formalin for 48 hours and sent to histopathology unit and was stained with HN. So apart from the histopathological evaluation, we obtained demographic details, medical records, and lab investigations, which showed us that out of 51 patients, more death was seen in males than in females. And the age distribution was more in the elderly population, predominantly between 50 to 60, followed by 60 to 70 years age group. The most common comorbidity which was seen was a diabetes mellitus, followed by hypertension and then ischemic heart disease. And also seen other were chronic kidney disease, bronchial asthma, and chronic liver disease. Now, the values of inflammatory markers in these patients were raised by more than 2 standard deviations. Pneumonia, both of these indicating that the lung was a major organ which was involved in COVID, followed by septic shock, indicating that the increase in inflammatory markers were responsible for the septic shock. Next, the acute and chronic renal failure, and the other cause of deaths were myocardial infarction, viral meningitis, type 2 respiratory failure, intracranial bleed, and hepatic encephalopathy. Now, coming to the histopathological observations that we found in our study in the lungs. So, most out of 51 patients, two patient samples were found to be inadequate. So, out of 59 patients, 44 patients showed diffuse alveolar damage, and early diffuse damage and hyaline membrane was seen in 14 patients, followed by proliferative and organizing diffuse alveolar damage seen in 20 patients, and then late diffuse damage seen in 10 cases. Now, the presence of microthrombi was seen at 21 patients. It was seen in 21 patients, followed by type 2 pneumocyte hyperplasia in 15 patients, intraalveolar hemorrhage in 12 patients, interstitial pneumonia in 4 of the cases, 6 cases showing pulmonary edema, and 1 single case showing lung abscess. Early diffuse damage. This is a microphotograph of a lung showing widened interstitium, showing inflammatory infiltrate, intraalveolar hemorrhage, and hyaline formation. This is a microphotograph showing widened interstitium with increase in myofibroblast proliferation, type 2 pneumocyte hyperplasia, and along with the presence of multinucleated giant cells. The fibrotic phase, which shows the wide interstitium being replaced by increased collagen deposition. Presence of microthrombi, which was seen in 21 patients. Other additional findings were pulmonary edema, interstitial pneumonia, and intraalveolar hemorrhage, and a single case of lung abscess. Now, the changes seen in myocardium were predominantly myocardial hypertrophy in 39 cases, followed by interstitial fibrosis in 8, and myocarditis, most probably neutrophilic in 6, followed by lymphocytic in 2. This is a microphotograph of the myocardium showing increased neutrophilic infiltration, and this is a microphotograph showing plasma lymphocytic infiltrate. Findings seen in the kidney were predominantly tubules were more involved than glomerulus, and in the tubules, cloudy degeneration was seen in 24 patients, followed by thyroidization of tubules in 7, and followed by tubular atrophy in 6. The glomerulus showed glomerular congestion in 18 patients, followed by glomerular sclerosis and mesangial proliferation. Interstitial inflammation was seen in 12 patients and hyaline arteriosclerosis was seen in 9. This is a microphotograph of the renal tissue showing cloudy degeneration of the tubules. This microphotograph shows the glomerulus which is sclerosed, and this is an ovoid eosinophilic nodule which is seen in the mesangium, which denotes diabetic nephrosclerosis. The liver showed histopathological findings of portal triaditis in 30 patients, followed by sinusoidal dilatation and congestion in 29 patients. Vascular degeneration and microvascular fatty change was seen in 22 patients, followed by central venous congestion in 14 and cholestasis in 5. This is a microphotograph of the liver showing sinusoidal dilatation and congestion, and this is showing portal triaditis. This is a microphotograph showing microvascular fatty change, and this photograph shows the hepatocytes which show increased bilirubin pigmentation. Spleen, out of the 46 satisfactory samples, sinusoidal congestion was seen in 22 of them, with expansion of the red pulp and white pulp atrophy. Discussion: the inflammatory markers which were raised in our study found to be a strong factor which was associated with disease severity and mortality, and which was also seen in these studies. Now coming to the lungs were predominantly involved as it was seen in the clinical finding as well as the radiological findings of ground glass opacity and consolidation, and which matched with our finding, which is a diffuse alveolar damage and predominantly the proliferative type of diffuse alveolar damage, which was seen similar to the study conducted by Karsana. And what happens is the virus binds to the ACE2 receptors, and these ACE2 receptors are present in the entire epithelial lining, and this causes decrease in the ACE2 function, and there is increased dysregulation of the renin-angiotensin system, which results in increased vascularity, increased vascular leakage and inflammation, giving a picture of ARDS. Hyaline membrane formation, type 2 pneumocyte, intraalveolar hemorrhage and pulmonary edema, and microthrombi, which was seen in our study, was also seen in a study in Bradley. Then endotheliitis and tracheobronchitis, these findings were not seen in our study, which was conducted by Borzo, because our study was a minimally invasive study and this study was a complete autopsy. Similarly, pulmonary embolus was not seen in our study, which was conducted by Wigman, followed by viral cytopathic effect, which was seen in a study conducted by Liu, which there was increased cytomegaly, nucleomegaly, increased eosinophilic nucleoli and cytoplasmic inclusions. Fibrinoid necrosis of the vessel wall not seen in our study, which was seen in a study by Kane. Now coming on to the biological findings in the heart, which showed in our study it showed myohypertrophy, inflammatory infiltrate and fibrosis, which was also seen in similar study by Duarte, Neto and Tian. And the pathophysiology of cardiac involvement, it could be either direct because ACE2 inhibitor is present in the cardiac myocyte, but it could also be indirect due to the inflammatory response, and these patients have underlying cardiovascular comorbidity which should be taken into consideration. The findings seen in the kidney, most were acute tubular injury, which in our study, which matched with those of study conducted by Santoriolo, and it indicates that tubules were more infected than the glomerulus, and this is because the ACE2 is present in the apical brush border of the tubules, and therefore there is more tubular injury. Arterionephrosclerosis and glomerular sclerosis, which was seen in our study, was also seen in study by Su and Bradley, and it indicates the underlying, and it may be due to the comorbidity of diabetes and hypertension. Next, the liver. The liver findings in our study, sinusoidal dilatation, microvascular steatosis and portal triaditis, were seen also in study by Tian and Wee. And cholestasis was also seen in our study, is rare but is seen in the study by Wee. Centrilobular necrosis was not seen in our study but was seen in a study by Fiel and Zigal. Spleen showed unremarkable histopathological change in the in splenic congestion, white pulp atrophy, and decreased lymphoid population, which was seen also in a study by Su. So to conclude, pathological changes were seen in all organs, which is COVID-19 is a multi-organ process. Minimally invasive autopsy technique, which was performed, is cost effective and it is easy and rapid. It could rapidly be able to reproduce. And it reduced the exposure to healthcare workers. And accuracy and diagnostic yield can be enhanced further by addition of CT imaging.
Thank you, Dr. Melody, for that beautiful paper.